Assalamu alaikum and good evening to you all. Welcome to another medical educational program by ACB Bangladesh chapter. We call it Health Talk on Acute Medicine, organized by ACB Bangladesh chapter and supported by Bangladesh Society of Medicine. Today we have come to the fifth episode of our series. On this episode, we are going to talk about another most important yet confusing emergency in medical science. Today's topic is gastrointestinal bleeding. To talk about this important topic, we have one of the most potential physicians of our country, a true leader, a living legend who have become a prodigy in the field of medicine. He is none other than Professor Khan Abul Kalam Azad sir. He is the governor-elect of ACB Bangladesh chapter and past president of Bangladesh Society of Medicine. To chair the session, we have another legendary professor here with us, who is considered one of the best physicians of our country, a true perfectionist and a true good human being, Professor H.A.M. Nazmul Ahasan sir. He is the current governor of ACB Bangladesh chapter and former president of Bangladesh Society of Medicine. As a panelist, we have two most renowned professors of our country. Firstly, we have the talented Professor M.D. Faizul Islam Chowdhury sir. He is the Professor of Medicine, Anwar Khan Modern Medical College and former Secretary General of Bangladesh Society of Medicine. We have also one of the most skilled professor and every student's favorite professor, Professor Sujat sir. He is the Professor of Medicine, Chittagong Medical College. To moderate the session, we should have Dr. Chowdhury Tamanna Tabassum Apu here with us. But as she was unable to attend due to an avoidable reason, today's program will be moderated by Dr. Shinjini Sarkar. She is the medical specialist at Sir Solimullah Medical College. During the live session, you can ask topic-related questions on the comment section. We shall try to answer them in the question and answer session, which will start right after the presentation. So, without doing any further delay, let me hand over the session to Dr. Shinjini Sarkar. Dr. Shinjini Sarkar.
Thank you, Dr. Prince, for your brief but nice introduction. Honorable Chairperson, respected panel of experts, honorable speaker, and learned audience. Good evening. Welcome you all to today's health topic on acute medicine. Today, our topic is gastrointestinal bleeding, which is most important and challenging component in the domain of acute medicine. We are extremely lucky to have the legendary Professor Khan Abul Kalam Azad sir as our honorable speaker today, who hardly needs any introduction. We are also honored and privileged to have another two renowned physician of our country with us today. I do cordially welcome Professor Faizul Islam Chowdhury and Professor Sujat Paul as the panel of experts. Today's whole session will be chaired by Professor Nazmul Ahasan sir, the living legend of internal medicine in Bangladesh. Sir is also the current governor-elect of ACP chapter Bangladesh. Dear audience, please feel free to comment or ask any question in the comment section during the presentation. Now, without any further delay, with the permission of the chair, may I have the honor to request Professor Khan Abul Kalam Azad sir to start today's session. Please, sir.
Thank you very much, Dr. Shinjini, for wonderful introduction of the session, and also Dr. Prince. And Honorable Chairperson, our great teacher and mentor, Professor H.M. Nazmul Ahasan, Honorable Governor, SAP Chapter Bangladesh, and also present here today are two very eminent professors who devoted their lives in medicine, Professor Faizul Islam Chowdhury and Professor Sujat Pal. Both of them are very close to me, very wonderful personality, and definitely they are very important in the session and in the show, because you know that their opinion regarding the session will be very important for the students. So I want to give thanks to American College Bangladesh because for arranging this type of topics. And managing acute problems in the emergency room is really a challenge for the physicians. and there, every moment, every single second is very important for the patient. And there are so many components to be considered whenever there is an acute emergency, and you need a comprehensive management of the patient regarding your skill in the history, skill in the physical examination, skill in the investigations, and the management plan. But in emergency, you need only one component that should come first. You have to begin the management, and then you can go for a short history. Accordingly, you can go for investigation, and then for future prevention and planning. So many things are there. And among all those emergencies, GIT bleeding is one of the very important issues, because that it can occur in such an intensity that the patient can die. And it, on occasion, the GIT bleeding may remain hidden and unsuspected. Only the patient can complain of your vertigo. So with this few words, I will go very quickly. The second slide, please. So the second slide, you see that if I say a 60 years old male having a complaint of large amount of bleeding from the rectum, he noticed the bleeding from the rectum, and this was large volume and very dark maroon colored stool. And last 3 hours he had to go to the toilet for 4 times, and 4 times he had this type of your complaint. And he is complaining that he is having lightheaded feeling and just nearly passed out upon trying to get up to go to the bathroom. So this is very important, that he cannot move clearly. So that is one of the issues, that the amount of bleeding he saw, whether it is it is all or something there, we have to notice. So on examination, when he is in the emergency room, the doctor is you, and you examine the patient. The blood pressure was a little bit low. The third, next slide, please. And you see the blood pressure is a little bit low, 105/70, pulse is a little bit tachycardia, and there were some orthostatic changes. The patient was, alert, oriented, but the thing is that he was a little bit anxious. And you examine for jaundice, he was not jaundice. And you found in the abdominal examination that a little bit of your liver was palpable, and the splenomegaly was there. And you did the DRE, and rectal examination found just only a little blood came out on your finger. And immediately you sent the blood, and you found that hematocrit was 21%. And you see the platelet was 100,000, and blood urea nitrogen 34, creatinine was 1, albumin was a little bit low, 3, INR a little bit raised, 1.6, and liver enzyme ALT was 71. So this is one picture I'm putting for you. We'll discuss in detail later. Next slide, please. Another scenario I want to put it forward: a 61-year-old woman presented with consistent discomfort, significant weight loss, and had a tarry stool. In the earlier one, we found that he had maroon stool, but it is tarry stool in the early morning, which she had never experienced earlier. And for the last 2 months, she has got a little bit of your epigastric pain, which is burning in nature, and it goes to the chest. And she takes aspirin and drinks coffee regularly. And she found a remedy, that is your by antacid. And another important thing is that she lost about 10 pounds in 2 months due to decreased intake caused by the feeling of bleeding. So whenever she takes food, and there is a little bit of fullness in the abdomen, and there is pain in the abdomen over the stomach. So she described this stomach is aching. And in the recent time on history, you found that she has got osteoarthritis, she has got knee involvement, and she was taking more NSAID in the few weeks earlier. And on examination, she was found a little bit anemic, pale, and she was a little bit exhausted. So this is another picture in our context in the emergency. So next slide, please. You can see that as a doctor, we found that in some patients, we got the history, we found some findings in the abdomen, we went for some investigation. But as a physician, Immediately after finding this type of history and history of maroon colored stool or tarry stool, we have to go for some thinking immediately, the differential diagnosis and where from the blood is coming. That is the very important, because you have to treat the patient accordingly by thinking of a perfect diagnosis, because the source of bleeding may be an important indicator by which you can make a diagnosis. That is very important. And but very importantly, whenever you are assessing the patient regarding your the source of bleeding diagnosis, but very importantly, we need a good resuscitation immediately. That should not be delayed. The history is to be taken in a very short, and most importantly, we have to go for resuscitation. Next slide, please. So if we go for GI bleeding, we can think of some epidemiological aspects. We know that GI bleeding we divide into upper and lower GI bleeding, and etiologically, and also depending on the prognosis and other factors, we divide anatomical, and classification is very much needed to find out the cause. Upper GI bleeding, it is found that it is about 67 per 1 lakh population. Lower GI bleeding a little bit less, 36 per 1 lakh population. And in men, the lower GI bleeding due to some sort of your conditions prevailing in the lower GI, the bleeding is common in the male. And definitely, any type of bleeding from the GI, the incidence increases with age. Next slide, please. So here I'm showing you a little bit, the GI tract, the ligament of trees, the dividing into, the upper and lower, the lower GI tract. So from the pharynx, the GI tract starts, and up to the rectum, we can see that the patient has got the sources of your lower GI bleeding if it occurs. Next slide, please. So we'll talk first on upper GI bleeding. Next slide, please. So regarding upper GI bleeding epidemiology, I will say a few words. In our country, on many occasions, we don't have a very good epidemiological study. We have got some study reports in our country which are very patchy and sporadic, but we found the study reports in the United States and the United Kingdom. And it is in the United States, upper GI bleeding occurs in 100 per 1 lakh population, and in the United Kingdom, they say that about 70,000 hospital admissions each year occur due to upper GI bleeding. So also it occurs in other parts of Europe, especially in Spain, and it has been shown in Spain that upper GI bleeding occurs more frequently, about 6 times more commonly than the lower GI bleeding. So this is very important, and it occurs in men especially, and when the person is older, it occurs more commonly. That is also important. So, but the thing is that when it occurs in male, female, death rate is almost equal in both the genders. But we have got so many advances in your diagnosis and different types of therapy. But the thing is that why this upper GI bleeding is important? Because in hospital mortality, it is very high. About 13% of the people die when they come with your upper GI hemorrhages. And another important issue is that after occurrence of a GI bleeding, if it is sealed, either spontaneously or by therapeutically, but the rebleeding is another important risk factors which can kill the patient. So that is one of the important issues. So to understand the upper GI conditions, usually we talk about, due to Western influence, we call it either variceal or non-variceal. We'll talk on these two issues. Now we'll try to find out anatomical conditions to produce this type of bleeding. Next slide, please. So if you begin this with esophagus, then we go to the stomach and then duodenum, then the upper GI conditions. Esophageal varices comes as the first condition to be considered when they come to the hospital with your either recurrent bleeding or profuse amount of bleeding. So that is one important issue. And also some form of esophagitis can produce bleeding, and definitely esophageal cancer is one of the important areas which is to be evaluated in all the patients when there is a bleeding, upper GI bleeding. And sometimes, due to drugs or other conditions, the esophageal ulcers can occur due to your corrosives or others. You can find that there can be bleeding. So fungal moniliasis and others, they can produce esophageal ulcers. And a special particular type of your ulcer, which is produced due to a tear in alcohol, it is your Malaria Waste tear. And among the stomach conditions, the very importantly, or everybody knows about the gastric ulcer. So the term gastric has been used by everybody in such a way that anything related to the stomach, it is, overwhelmed by that some form of your ulceration in the stomach. So everybody, whenever they try to point out that something is happening in the abdomen, I have got gastric. So, but the thing is that for the physicians, we know that the stomach is an important area where the bleeding is to be looked for. And in conditions like your gastric ulcer, gastric cancer, and sometimes gastritis. But the thing is that on occasion, we can find the gastric varices in the fundus. They can produce your obscure GI bleeding. That is an important area which is to be sought out. And among the duodenal condition, the most common is your duodenal ulcer. Still, duodenal ulcer occurs in population after introduction of PPI and other drugs, but still we find the patients with duodenal ulcer. And very importantly, we can find that sometimes the vascular malformation or there can be formation of aorto enteric fistula with a duodenal and aortal fistula, which on the posterior wall due to ulceration. So definitely it is an area which is to be evaluated. And some uncommon conditions, and three of the uncommon conditions here we have described here. One is your hematobilia, that is from the biliary tree, the blood can come in the duodenum, and also Hemosuccus pancreaticus or pancreatic duct bleeding, and another is your supramesenteric artery syndrome when there can be some sort of bleeding. In the next slide, go, please go. And this is a very common picture. And all the doctors, they try to remember this British picture, that the sources of bleeding and the conditions to produce this bleeding, and also the percentage in which you can find the upper GI bleeding. So I think I don't want to repeat this one, but I will say that is still the commonest condition here depicted, that peptic ulcer disease due to NSAIDs or Helicobacter pylori in 35 to 50%. That is the most important area. Then your esophagitis. And the third one is your gastric erosions. And the fourth one you can find the patient can have varices. Next slide, please. So upper GI bleeding, they can produce various types of symptoms, and also you can find signs. So in general, for a doctor, they can ask so many questions. I will go to the history taking, but the thing is that whether the patient has got hematemesis only, or the patient has got melena only, or both, or the patient has got fresh blood per rectum, whether the patient had an attack of syncope, whether the patient has got a history of dysphagia or any upper GI tract disturbance or upper abdominal disturbance, whether he has got pain in the epigastrium, whether he has got pyrosis or heartburn, whether he has got diffuse abdominal pain, whether he has got any difficult swallowing, or very importantly, two signs, weight loss and jaundice. Always to remember, these are two very dangerous red flag signs. Next slide, please. Now you see that I have mentioned that either this upper GI bleeding can occur singly in the form of hematemesis, melena, or hematocritia, or in combination. So this can happen. So we know that hematemesis is vomiting of blood. So the blood, when it is in the stomach, it is digested. So it becomes your with your coffee ground in color, because you know that when there is slower rate of bleeding, so it has got the time to mix with your hydrochloric acid, they produce acid hematine. So that is your coffee ground in color. But sometimes the bleeding is huge, so that can be fresh blood passing all through, and the patient can have either your fresh blood per mouth, or they can have hematocritia. That is important. And you know that if this partially digested blood, it goes down So it becomes black and tarry, semi-solid, and it has got a very distinctive odor and is very shiny in color. And that the blood has been present in the GI tract for at least 14 hours. That is an important point to remember, that it was there and then gradually it is coming down. So if the bleeding occurs more proximally, so more risk of having melena. And you know about hematocritia is a matter of your very much your lower GIT or procto anal problems. But the thing is that occasionally upper GI bleeding can produce a diagnostic dilemma when you find hematocritia, because you know if there is your huge bleeding that can produce your hematocritia, so it can go down without being mixed. So that is very important. That is the area. So we have mentioned this point. Now straightforward, I will go to history taking. Next slide, please. So what are the important points in the history for a doctor when he receives the patient? Very importantly, I will discuss about the mode of onset, character of the blood, and the extent and rate, and some other points I will say, like your other associated features, iatrogenic factors. I will discuss later. But the thing is that what is the onset, when it occurred first, and so the either single hematemesis or single melena or both occurred. So that is very important. And whether you know that some of the conditions which can mimic your hematemesis, because any form of blood in the oral cavity or coming to the oral cavity, either from the nose or from the gum, from the respiratory tract. So all these things you can produce your bloody, vomiting. So this is an important area. You have to exclude that bleeding from the nose, blood mixed sputum, or a dental extractions. Very importantly, mode of onset and character of the blood, which is seen. What is the color, the appearance of the vomited blood? It is red, dark red, brown, or black, or coffee ground. So this is very important. By seeing the color, you can understand that how much blood is there in the stomach, for how long the blood is there. So very importantly, and whether it is bright red and frothy, when it is rapid and brisk. So and also you have to inquire about the stool color. It is bright red or black or tarry. So these are the points. And you have to identify the extent of blood loss and also the rate of blood loss, by which you can assess how emergent the condition is. So what are the number of times when the patient vomited or went for a black tarry stool? So it was abrupt or massive, or one more than one tarry stool within 24-hour period. That is very important. And for how long the tarry stool persisted. So this is the extent and rate. You can assess the patient that he already lost how much blood in the bleeding episode. Next slide, please. And associated symptoms are very important. That what type of your associated manifestation in the GI tract, like your retching, then your non-bloody vomiting was there or not. What about lightheadedness? Whether he has a nausea, whether he feels thirst, how much sweating was there, whether he feels your impending fainting, or when, especially when he's trying to stand from the sitting or lying position, whether he feels like that, and also whether he had any type of your diarrhea afterwards. And very importantly, iatrogenic factors are very important to know about that, as we found in our one of the patients, that after taking your NSA, she started having more, difficulty and also more bleeding. So aspirin, anticoagulant therapy, and also another important factor you have to remember: iron doesn't produce your bloody hemorrhages, but the thing is that iron can produce the same type of your black stool. So tarry stool can be misnomerly be said that it is due to hemorrhage, but iron is one of the factors that is to be considered very seriously to exclude your iron therapy in all these cases. And also, the age of the patient, and what about the smoking and alcohol? You know that alcohol directly produces damage to the stomach and duodenum, and it can produce your ulceration. And also smoking delays the healing of ulceration, so that is very important. And also, the previous episodes we have to ask that whether he had similar episodes and exactly when he had this type of episode, and what was the diagnosis, whether any diagnosis was made, and whether he had to go to the hospital and how many times, and whether he was transfused or not, and any family history, especially some diseases can occur in the families, so they can have your other family members who can have same type of episodes. So after taking this type of history, we are going to the physical examination for upper GI bleeding evaluation. Next slide, please. Now you can see the general inspection that should be covered, that how much anemia is there. You know that immediately after a bleeding episode, immediately you may not find the patient is anemic. So in a patient who has got GI hemorrhage, and then you find that the patient is anemic, it means the blood is going out for a long period of time. So that is important. And whether he has got any bruising or purpura, to find out any coagulopathy or hematological disorder or any liver disorder, we have to find it out. What about the weight loss, whether the patient is cachectic, how much dehydration the patient is having, whether the patient is having your jaundice or not, that is very important. And abdomen examination is very important. You have to go for that full abdominal examination, inspection, whether abdomen is distended, what about the umbilicus, what about the veins, and then you palpate the abdomen, any tenderness, whether you feel any organomegaly or any masses in the abdomen. All this to be evaluated, any liver, spleen, any mass like lymph nodes or something like that. So you have to evaluate that very clearly. And percussion is also very important. We have to find out whether the patient has got fluid thrill or shifting dullness to indicate your ascites. And also you have to see that whether there is any bowel involvement, like your hyperactive bowel sound in some form of your bowel obstruction or like that. And rectal examination is a mandatory part. Here also, in some form of your upper GI bleeding, we can find that the patient can have some evidences that they can have at the same time perianal skin lesion, and that is very important. That in case of your Crohn's disease, we know that, and you can feel the masses or you can find melena. And lymph node examination is very important for this patient, and especially the left supraclavicular lymph node to exclude any form of stomach malignancy or lymph node present anywhere in the body to find out a differential diagnosis. And CNS examination, especially the higher psychic function examination, is very important to assess the amount of orientation in the patient, and then you have to find out exactly any type of a neurological deficit, whether present or absent. Next slide, please. To continue the physical signs, then if you will find that the systolic blood pressure is less than 100, pulse rate goes high more than 100, and any type of your postural instability, so you can find that the patient is going into shock. So you have to assess the patient clinical shock, and also any type of other liver disease, stigmata of your chronic liver disease. So that is very important. And any form of your sign of GI disease, and then sign of bleeding abnormalities, and rectal examination. So these are all important that in the patient you have to examine, and then clearly you will get some idea that I have found this sort of thing, so the probable differential diagnosis will be like this. Next slide, please. We have to go for investigation. So in every patient, we have to go for CBC with platelet count. Full hematologic evaluation is needed in every patient. Then you assess the hemoglobin value. You go for your RS typing, and also immediately you send blood for cross-matching, because at any moment you may need to go for blood transfusion. So that's very important. And every LFT is important here. You have to exclude LFT. Even if you don't suspect any liver disease, then go for liver function test, and also to evaluate the patient's renal status, whether how long the patient is having as a renal function test. And also you have to you know that one important condition, we know that there may be peptic ulcer, your calcium level in the patient. So that is very important. And also on some occasion, you have to go for gastrin level estimation, especially when you find the patient has got resistant ulcer in the peptic in the stomach, or the with your convoluted, very important. You next slide. Yeah, then we have to go for the bun to creatinine ratio. So that is very important. That can give you a guideline that whether it is your due to renal dysfunction or without renal dysfunction. So usually, if the bun to creatinine ratio is greater than the patient has got upper GI bleeding, and if you see the patient has got no renal insufficiency, definitely, and prothrombin activated partial thromboplastin time, and I in chronic liver disease, that is very important. So that is important to address the addressing the protein estimation, albumin, globulin, very important.
Sir, sorry for interruption, but I think your we cannot hear you well, sir.
Investigation to address the most important.
Uh, I guess there was been technical difficulties. Sir will be back soon. Sorry for the inconvenience.
Okay.
So can you hear us, sir? Sir, can you hear us, sir?
আমি তো শুনতে পাচ্ছি এখন। আমাদের কি হয়েছিল এটা? আমারটা
স্যার যে
ডিস্টার্ব?
নেটওয়ার্ক, জি স্যার আপনার নেটওয়ার্কটা স্যার এখনো স্যার ওই যে কাটা আসতেছে স্যার কথা।
ও
স্টিল একটু
আচ্ছা,
প্রবলেম আছে।
আমারটাই খারাপ। আমি দেখি আরেকটা আমি ব্যবস্থা করলাম। এখন কি দেখতে পাচ্ছ?
জি স্যার।
ওকে, আমি এটা দিয়ে যাই। আমি আরেকটা ব্যবস্থা, নেক্সট ইনভেস্টিগেশন লাইক ইওর চেস্ট এক্স-রে।
থ্যাংক ইউ স্যার, এখন অনেক বেটার স্যার, অনেক বেটার স্যার, থ্যাংক ইউ স্যার। আবার কি হলো? স্যার
and also okay, এখন কি শুনতে পাচ্ছ?
স্যার কোনটা লাগবে স্যার?
ও তুমি দুইটাই আমি এটা ওই আমার আইফোনটা রাখি, এটা ল্যাপটপটা আপাতত ই করে রাখে, আমি এটা দিয়ে।
জি স্যার।
সো আদার ইনভেস্টিগেশন শুনতে পাচ্ছ এখন?
জি স্যার, ক্লিয়ার স্যার।
Okay, we can go for chest X-ray to whether there is any pulmonary involvement, especially aspiration, pneumonia, and effusion or esophageal perforation. We can go for abdominal X-ray, erect at any perforated viscous. And then on occasion we have to go for ultrasonography and computed tomography on occasionally. And sometimes nuclear medicine scans can give us some idea. Next slide, please. And we can go for angiography. Angiography is not a very common investigation. Not always it is done. And when the bleeding persists for a long time, and endoscopy fails to identify a bleeding site, so at the time we can go for angiographic evaluation. So that is also one area important I understand, especially as I mentioned, duodenal-aortal fistula. Then angiography may be required to find out the active bleeding. Next slide, please. So we know about there are some scoring system, risk stratification scoring system, and we have got several. And I have put here 3 scoring system, and you know about that. These are the 3. I'm not going into detail. That some of the facts are taken into consideration, and then this scoring system, especially roll call or blood sport, they all are considered by considering your age, then shock, comorbidity, all these things. So next slide, please. Next slide. Next slide. Now we will be considering, after this type of scoring, that exactly where the patient is. Next slide, please. We now will go to the management. And for managing the patient, there are some priorities that, the stabilize the patient, and ABC is very much essential. Airway, breathing, and circulation are very important. Then we have to identify the source of bleeding. Then we have to find out the cause, and then exact treatment is needed for the patient. So, but very importantly, whatever may be the source, whatever may be the cause, we have to resuscitate the patient. So we have to go for ABC. Then IV access is very much important. 1 to 2 large bore cannula is to be given, and then hemoglobin, PCB, prothrombin time, and cross matching all to be done. And we have to go for stabilization of hemodynamic. The normal saline is a very good option here. Then we can go for other type of your volume expander like colloid, and then crystalloid, and until blood is available, you can continue like this. And after getting the blood, you can go for your transfusion. So that is very important. Next slide, please. So transfuse, when the blood is to be transfused. So we have to transfuse the blood when there is obvious massive blood loss. So that is very important. And hematocrit is less than 25% with active bleeding. And symptoms due to low hematocrit and hemoglobin, you can find the patient is going to have syncope, or he has got persistent DG spells, or he has got shock. So we have to go for like blood transfusion. And if the patient has got your platelet deficiency less than 50,000, we can go for platelet transfusion occasionally. And who have got low fibrinogen level, so then we can go for a fresh frozen plasma infusion in the patient. But remember that over-transfusion should not be done. Next slide, please. Then after getting all these things, we have to monitor the patient. Very importantly, we have to find out the renal function by monitoring the urine output. And we have to check the JBP. And we have to auscultate the lung bases, and whether there is peripheral edema to exclude any infusion. So that is very important. So, and then immediately, in all cases, we intravenous PPI, omeprazole 80 milligram IV, followed by 8 milligram per hour for 72 hours to be infused in the patient. And till the endoscopy is done, then the patient should be kept in empty stomach. Next slide, please. So we'll go to the variceal bleeding and then the non-variceal bleeding. In the variceal bleeding management, emergency management of bleeding, and the IV fluid is very important. So we have to go for extracellular volume replacement, and then immediately we have to go for vasopressor. Terlipressin is to be given here, which reduces portal pressure and also reduces the risk of acute bleeding and risk of early rebleeding. These all can be done by terlipressin. So for that reason, terlipressin is given earlier. And also prophylactic antibiotics are to be given, which reduces the incidence of your spontaneous bacterial peritonitis. That is another important complication. And then we go for endoscopy. Then we confirm the variceal bleeding, and then we think of your variceal band ligation emergency to stop bleeding. And if the patient has got this variceal bleeding, still the risk of peptic ulcer is there. To prevent peptic ulcer, we continue proton pump inhibitors. And also remember, for the variceal bleeding, we have an important component to prevent, that is your hepatic encephalopathy. So for that reason, we have to go for your enema or lactulose therapy. In the next slide, please. So in the next slide, the flow chart, the same thing what I've mentioned here, it has been described here. Next slide, please. So for the this bleeding, for esophageal varices, we usually go for band ligation or stent insertion, which is also effective in some selected patients, but not for all. But the tips can be done in some centers. Still, the tips is done, but in our country, that tips is not done here till today. And for the gastric varices, we go for endoscopic examination, injection of some sort of your coagulant, and also tips can offer some sort of your help to the patients. Next slide, please. We'll now go to the emergency management of non-variceal upper GI hemorrhages. So very importantly, the students are asked in the OSPE examination. This is a very effective chart to remember for the examination purpose, and also to practice in the clinical life. So we go for IV access, and then full blood count, routine biochemistry, coagulation screen, cross match, then hourly blood pressure, pulse and urine output, and also central venous pressure monitoring, and then IV crystalloid in the normal saline, and then we have to go for your blood transfusion, and then endoscopy examination organization, and then proton pump inhibitor, and then also we go for your surgery or interventional radiological procedures like arterial embolization if bleeding recurs. That is very important. So in the next two slides, I will show that endoscopy is now the method of choice for controlling active peptic ulcer related upper GI bleeding. So that is very important. And also you can see the visible vessels. So that is important. And also one important point I want to mention, whenever there is a that you want to stop the bleeding, and it was a previous practice that perilesional adrenal injection to make the vasoconstriction was a very important choice, but now it has been said no, don't go for adrenal injection. So next slide, please. So we go for mechanical methods like your clipping. So it can be used with adrenaline also. Thus, that is very important. On occasion, there may be your thermal coagulation, and also there may be fibrin or thrombin can be given with adrenaline. So that is very important, that by interventional radiology, when the patient has got rebleeding, we can go for the interventional radiological help for unstable patients who rebleed after endoscopic treatment. And on occasion, we have to go for surgery. Next slide, please. So if the patient has got persistent hypotension or failure of medical treatment of endoscopic hemostasis, or if there is perforation, obstruction, or if you suspect a malignant condition, or if you find that transfusion is required much more than anticipated. 4 units in 24 hours is a very important indication for surgery. And also in the patient after first hospitalization, when he did not require any surgery, if the patient comes on the second time, then surgery is the important method of treatment for this patient. So on occasion, we find the patients can have a high mortality, about 13% in the hospital. But when you find the resource constrained areas, the mortality can be much more. So there are some risk factors to be thought of in patients who can have death. Next slide, please. So if the next slide, please. Next slide. So risk factor of death occurs in patient when advanced age and shock on admission, and if there is comorbidities, and the patient has got a malignant lesion, and the endoscopic finding shows that active spotting hemorrhage from peptic ulcer, or non-bleeding visible vessel, and rebleeding on several occasions. All these factors are very important to consider, and they increase the risk of mortality. Next, we'll go in the next slide. We'll talk a little bit about the esophageal varices, which is also very important. We can see in the photograph the esophageal varices. So we know that it is the vascular dilatation, and it occurs at the lower esophagus. Next slide, please. And we all know about the pathophysiology of esophageal varices when there is, increased portal venous pressure. So many times there is your portal systemic shunting. So there is ultimately, there is your dilatation and the formation of the varices. Then next slide, please. And when you will see that the patient has got bleeding from the esophageal varices, it is usually of sudden, painless onset, and usually the patient has got large volume of blood being vomited, or in the melena it is dark red in color, and the patient will get definitely a history of viral hepatitis, alcohol liver disease, or Wilson disease on most of the occasion. And you can see the abdominal distension with ascites. That is very important. So ascites and splenomegaly two findings are very important in this condition to consider esophageal varices rupture. Next slide, please. Next slide. Now, a few words about Malaria Waste here, because on postgraduate courses or in examination, Malaria Waste tear management may be an important issue. Longitudinal. So, a longitudinal tears of the esophagogastric junction. So, the patient can have some precipitating factors like hiatus hernia. After alcoholic drink, the patient can have retching and vomiting, or straining, hiccuping, coughing, and on occasion, blunt abdominal trauma or cardiopulmonary resuscitation can produce tear in the esophagogastric junction to produce Malaria Waste tear. So, the patient can have episode of hematomesis or melena or hematocritia. The patient can go into syncopal attacks, and the patient can on occasion have abdominal pain. And on occasion, it's an important issue for the surgeons to go for managing this Malaria Waste here. Next slide, please. So next slide. Usually, the surgeon takes the issue in about 10 to 20% of cases. In usually 80 to 90% cases, there is spontaneous, stoppage of the bleeding. So thermal modality, contact thermal application can be important, or heater probe that can also, or epinephrine injection along with, and also you can see band ligation and hemoclipping are the important methods for stopping the blood from the Malaria Waste tear. So from Malaria Waste tear, we'll go to esophageal cancer. Next slide, please. So it is a very common cancer. About among the ranking is the eighth most common, and usually in the middle third 40%, and adenocarcinoma is the cancer. Next slide, please. Next slide. So you can see the squamous cell carcinoma. There are some risk factors. I'm not going into detail, but remember that any patient having your tobacco smoking, heavy alcohol or plumber vincel, and also achalasia or celiac disease. These are the important factors when we can find the esophageal cancer, and also some vitamin mineral deficiency, the vitamin A deficiency, vitamin C deficiency, they can increase the risk of your esophageal cancer. Next slide, please. Next slide, please. So, yes. Uh, the most common is your dysphagia, because you have to know about the esophageal cancer, because you have to differentiate it from achalasia cardia, and also many X-rays, the barium swallow esophagus, are given in the OSPE to exclude the condition. So this is very important for the students. So dysphagia, when the patient can have painful swallowing, the odynophagia, and the patient can have regurgitation, aspiration pneumonia. The patient can have your anorexia and weight loss. Ultimately, the patient can have anemia. So, the very importantly, we have to remember this part, and definitely surgery is the curative form of treatment in esophageal cancer. Then we'll go to a very common condition, the peptic ulcer disease. And we know that peptic ulcer disease, it is caused by the imbalance between acid and pepsin and mucosal defense mechanism. We know that normally we have got the defense mechanism prevailing in the mucosa, and there is an imbalance and increased acid acting on the mucosa to produce peptic ulcer. But you know that there is Helicobacter pylori influence. You can find the NSAs. There can be stress, smoking alcohol, steroid, and also hypersecretory condition like Jollinger-Ellison syndrome. And the people have got symptoms like epigastric pain. They can have heartburn, but on occasion they can have hematemesis and melena. Next slide, please. So here is a little bit about the pathogenesis. When there is Helicobacter pylori infection and there is acid pepsin attack and breach of mucosal protection, there may be acute inflammation. At this stage, there may be resolution, but the mucosa may be destroyed through and through, and there may be your peptic ulcer disease. So that can produce perforation and peritonitis, and the patient can have massive hemorrhage. Next slide, please. So we know that the gastric and duodenal two ulcers, they compose the peptic ulcer disease, and we know some differences. You all know about that. One is that after eating, the pain is relieved, and after eating, pain is aggravated. After eating, it is duodenal ulcer. After eating, if it is aggravated, it is your gastric ulcer. So the people having your duodenal ulcer, they become a little bit your obese and plump, but in gastric ulcer, the people can become emaciated. So that is very important. And next slide will show you the complications of peptic ulcer disease, what is very important. And it is hemorrhages, which is very important. That is important, that posterior duodenal ulcer. It is a very common site of your bleeding, and also the ulcers occurring at the lesser curvature, they can bleed. And also in peptic ulcer disease, we know about there is perforation or there may be pyloric obstruction. Next slide, please. A little bit, synopsis. Next slide. About the medical management, that that we go for various forms of treatment has been discovered, but still antacid is one of the important areas which is been practiced, and really aluminum hydroxide, magnesium hydroxide, magnesium, trisilicate. These are all important areas where the antacids are prepared and then are very helpful for the patient for your cellular protection and neutralization. And also sucralfate acts by mucosal protection. And misoprostol is also practiced in some areas as prostaglandin analogs to repair the the broken mucosal layers. And the discovery of your H2 receptor antagonist really revolutionized your peptic ulcer management in the 60s. And cimetidine, the first H2 receptor antagonist, and then ranitidine and famotidine, and so many other dine are there. And proton pump inhibitor is another your breakthrough in the challenges of peptic ulcer management. And we are giving omeprazole, rabiprazole, pantoprazole, esomeprazole. So many zoles are there. And it is very important to eradicate the Helicobacter pylori by triple therapy. And on occasion, we go for surgery. And surgery is indicated on some occasion. In the next slide, please. So when there is perforation or massive hemorrhage or recurrent hemorrhage, we can go for surgery. So it is elective surgery. We can go for that surgery in peptic ulcer disease. Next slide, please. I'm not going into types of operation. Next slide, please. On occasion, serious diseases like gastric cancer can be there to produce your massive hematemesis and melena. So you have to consider when the patient has got obvious abdominal lump and cachexia, anemia, and vomiting, weight loss, then it is very easy. But in many patients, these signs are not found. That the patient can have little bit abdominal pain, or the patient can have for the first time he can have hematemesis and melena. So that is very important. Though I am talking about the cancer, but there are some benign gastric neoplasms, especially leiomyoma and the polyps you have to consider here very seriously. And next slide will show you some of the etiological factors about the gastric cancer in the older group. And especially, all these conditions can produce your important, they can contribute as the important risk factors to cause gastric cancer. Next slide, please. So already I mentioned the symptoms like anemia, weight loss, dysphagia, persistent vomiting, and the back pain. These are all very important to consider. And if you find an epigastric mass is not very common, and in about 30% people you can get the mass. But on occasion you can find the signs of metastasis, especially the liver involvement or the peritoneal involvement. You can find the patient can have jaundice or ascites. Next slide, please. So management is your complicated. We have to go for surgical procedures like radical total gastrectomy. We can go for palliative resection or palliative bypass, and chemotherapy may be there important depending on the condition. Next slide, please. The final part of the upper GI bleeding, I will conclude, Mr. Chairman, sir, with saying a few words about Deuteronitis, because in the GI endoscopy, they sometimes mention the Deuteronitis, but this is very common condition, especially after taking NSAIDs and also people having your hypersecretory state. This Deuteronitis may be an important factor to produce upper GI bleeding. And the patient will have symptoms like your peptic ulcer disease. The patient can have upper abdominal pain, and also the patient will have bleeding that can produce your hematemesis or melena. The patient can have nausea and vomiting, and anorexia may be there, which can be an important factor when there is bleeding in case of Deuteronitis. So in the next slide, we'll find one slide on upper GI, that the management, that very importantly, we have to take the history of whether the patient was receiving any NSAID or aspirin. We have to stop all that. Then we have to provide the patient with your ranitidine or cimetidine or proton pump inhibitors. They can reduce the secretion in the stomach. So I stop here on upper GI bleeding, and because GI bleeding was my topic, and I took about about 1 hour for upper GI bleeding, but I will go very quickly on lower GI bleeding. Uh, Next slide, please. So the lower GI. Next. So lower GI bleeding, about 20 to 33% of episodes of GI hemorrhage are under lower GI hemorrhage. Annual incidence of about 20 to 27 cases per 100,000 population in the Western countries. And then regarding the etiology in the next slide, Mr. Chairman, sir. So we all know that they can have your severe acute bleeding, or they can have moderate, chronic, or subacute bleeding. So we have seen in the books they prefer this type of your presentation. In severe acute, usually diverticular disease, when there is your diverticulitis, so that can produce your severe bleeding. And very importantly, I want to mention about one important factor, that is angiodysplasia, which is one of the important conditions to produce obscure bleeding on occasion, and also ischemic colitis, that is one of the areas. And on occasion, Meckel's diverticulum can be an important area from where the bleeding can occur, can produce peptic ulcer disease. And very importantly, inflammatory bowel disease, though it doesn't produce severe bleeding, it produces a moderate amount of bleeding in a chronic fashion. So among the moderate conditions, the chronic or subacute, all are surgical conditions mostly, Mr. Chairman, sir. But I want to mention about this inflammatory bowel disease, then angiodysplasia, and radiation enteritis, and also a benign condition like solitary rectal ulcer, which doesn't require usually any surgical intervention. Next slide, please. So this is the flow chart that massive bleeding, moderate bleeding, and occult bleeding. So we have to consider the age of the patient, and then hematocritia or bright red blood bleeding, then hemodynamic stability. We have to go for blood pressure and the heart rate or the urine output. We have to measure the hemoglobin, and also very importantly, diverticulitis and angiodysplasia. They produce massive bleeding, Mr. Chairman, sir. And very importantly, mortality is very high in this group of people. If not adequately managed, it is about 21%. Moderate bleeding can occur at any age, and hematocritia can occur, or also on occasion there may be your tarry stool, black stool. So on occasion it can occur, and the patient is usually stable, Mr. Chairman, sir. And the patient can include benign, anorectal, congenital, inflammatory, and neoplastic diseases. So there may be your moderate bleeding. And occult bleeding is one of the important areas which are to be dealt with the physicians on many occasions when the no source of bleeding can be found. So it can occur with any age, and microcytic hyperchromic anemia is the presentation. And the next slide will show you that the history is very important. Next slide, please. I will just make a jump to some rectal bleeding, so the patient can say that the blood is coming itself, or it is mixed on the wall of the stool. If it is your rectal, then polyps or prolapsed or carcinoma, and from the anus, the hemorrhoids and fissure in anal carcinoma, they are important, Mr. Chairman, sir. Next slide, please. So, you know that among with blood, the color of the blood is important, Mr. Chairman, sir, and also the discharge, whether there is any discharge along with the blood. So, if it is dark blood, so it may come from the upper GIT to above rectum, then it can produce dark blood stool. And sometimes the blood we have to consider iron tablets, or grease, and also we have to consider the discharge, Mr. Chairman, sir. In some patients like mucus the irritable bowel syndrome. The patient can have your copious mucus like villus adenoma or frank cancer. So I want to emphasize on this frank, cancer of the rectum, that the patient can have copious mucus. The doctor will not ignore this mucus secretion because that it may be an indication of your cancer. Next slide, please. So among them, we have to go for the history. So whether the patient has any altered bowel habit and so many other things. I'm not going into details. Next slide, please. These are all surgical, and but here you have to give the importance on the inflammatory bowel disease. What is the extent of involvement, and whether any investigation was done earlier to detect inflammatory bowel disease. So these are all investigations which are to be done. The all are similar to upper GI, but the thing is that here mesenteric angiography is important, scintigraphy is important. Next slide, please. And also, CT scan of the abdomen can be important. Next slide, please. And also, barium enema is important. On occasion, you can find that the patient can have the features of inflammatory bowel disease or a malignant obstruction. And the very important investigation is your colonoscopy or short examination by proctosigmoidoscopy. And also, you can go for esophagoduodenoscopy to exclude upper GI bleeding. And very important is colorectal polyp. And on occasion, we find that the patient can have polyp, and as because the polyp can be single or multiple, we should evaluate and go for surgery. Next slide, please. And we can see that the single polyp is there. Next slide, please. And a very common condition in some areas, the familial condition, the familial adenomatous polyposis, that is important to remember. In teenagers, we can find that the patient can have this type of your polyposis and the bleeding, and Gardner's syndrome is one of those conditions with osteoma of the mandible. Next slide, please. So here we can go for sigmoidoscopy or colonoscopy. These are the two important, and sometimes the barium enema examination. Next slide, please. So we have to go for, sometimes if it is multiple, we can go for colectomy and ileorectal anastomosis, or we can go for, after doing the polypectomy, then we can go for follow-up examination. Next slide, please. Adenocarcinoma is a very dangerous condition, and it is in older people, more than 60 years. So in sigmoid colon and rectum, it can occur. The patient can have tenesmus, and the patient can have rectal bleeding with anemia. Next slide, please. And because I mentioned about angiodysplasia, Mr. Chairman, sir, this is an important condition which can be there. So the patient are usually more than 60 years, and ascending colon and cecum are the important signs. Malformation can occur. The patient can have acute or chronic rectal bleeding. Next slide, please. So we can go for colonoscopic evaluation and mesenteric angiography. Next slide, please. Management, we can go for diathermic management of this by colonoscopy. Next slide, please. And ischemic colitis in older patients, they can come with your bleeding, with abdominal pain, and because of transient ischemia of a segment of a large bowel. And splenic flexure is the commonest site where this can occur. Next slide, please. Hemorrhoids, I'm not going to do that. If you suspect hemorrhoids, that the patient doesn't have pain, but they can have bleeding, and the patient can have external hemorrhoids along with. Next slide, please. So next slide, please. The patient can have anal fissure, Mr. Chairman, sir. The patient will have pain along with bleeding, and the patient can have fresh blood with defecation. Next slide, please. And on occasion, we know that diverticular disease may remain silent, but when it is, inflamed, and can produce diverticulitis with diarrhea and bleeding. Next slide, please. So medical management is very important. On occasion in the exam, diverticular disease management is important. The vasoconstricting agent vasopressin can be given. Therapeutic embolization can be used, and also endoscopic therapy with diathermy, laser coagulation, and short-term control of bleeding during sedation. They all can be the management procedures. Next slide, please. So surgical part is also important when you can go for surgical, but on occasion when the patient is older and chronic history and relapse, there can be a very bad prognosis and they can occur frequently. Next slide, please. So we have made a flowchart. I'm not going into details. Next slide, please. Next slide, please. So, this is the final part of my lecture, Mr. Chairman, sir. Within 1 or 2 minutes, I will finish. You know that some patients they can have your severe bleeding, but upper GI endoscopy or colonoscopy they may fail to evaluate the patient for the source of bleeding. So, the patient can have severe life-threatening bleeding. So, we can advise an urgent CT mesenteric angiography in this status. So, that will identify the site of bleeding. If the angiography is negative or bleeding is less severe, so we can go for double balloon enteroscopy, Mr. Chairman, sir. And sometimes the capsule endoscopy can be a procedure to find out and to evaluate the source of bleeding, especially when the patient is having your unknown site of bleeding. Next slide, please. So the patient is coming, or the but cannot be seen by naked eye. That is the occult bleeding, and in the colorectal cancer, we have to consider this as an important cause. Next slide, please. Next slide. So this is a very big list, Mr. Chairman, sir, to find out the causes of your obscure bleeding, and starting from the reflux, esophagitis, erosive gastritis, then diverticulation, antral vascular ectasia, portal gastropathy, Deuteronitis, celiac sprue, Baker's diverticulum, Crohn's disease, and also diverticulosis, ischemic colitis, ulcerative colitis, and some form of special infection, hookworm, whipworm, strongyloid. I want to mention one case of strongyloid. In our country, we found that with strongyloids, they presented with upper GI bleeding, and it was reported, Mr. Chairman, sir. And there may be fissure or hemorrhoids, or there may be your vasculitis, fistula, sarcoma, lymphoma, and also vascular malformation. And on occasion, we may not find any source. Next slide, please. So this is my, that the patient will have, the flow chart. So angiography, and then we can go for the specific management, or we can go for capsule endoscopy. Then we can go for right follow-up, or we can go for specific management. My final, next slide. So our take-home message is, Mr. Chairman, sir, GI bleeding management. So first of all, without doing anything, we have to assess the amount of bleeding, then stabilize the patient, and then we have to determine the source of bleeding, and we have to stop the active bleeding. Then any underlying abnormalities to be treated, and we have to prevent recurrent bleeding, Mr. Chairman, sir. So with these few words, I say that I took about 75 minutes to discuss this upper and lower GI bleeding. I'm very sorry if Mr. Chairman, sir, I just broken the attentiveness of the audience, but I feel that our audience, if they can just make a framework of upper GI and lower GI bleeding, in this light, they can get some help. So with these few words, I'd like to say thank you, Mr. Chairman, sir, for just giving me the opportunity to discuss in such a very important forum, and to everybody who are present, and especially our uh, expert members. Thank you very much, sir. Assalamu alaikum.
Thank you so much, sir, for this amazing presentation. Now it's time for the question and answer session. I can see many questions on the comment section, but we apologize because we won't be able to answer all of them. We'll select few as the time is short. So, without doing any delay, let me hand over the session to Dr. Shinjini Sarkar to start the question and answer session.
Thank you, Dr. Prince. I'd like to thank our honorable speaker for his wonderful presentation on this time-demanding topic. Before going to the question answer session, our renowned professor, Dr. Sujat Kawser, will leave us due to some unavoidable reason within few minutes. Before that, I would like to request sir to give his valuable speech upon the presentation now. Sir, Dr. Sujat Kawser.
Thank you, Shinjini. Am I audible to you?
Yes.
Am I audible to you? Okay.
Yes, sir.
Thank you, Shinjini, and thank you, SAP Bangladesh chapter, for giving me the chance to say something in this August gathering. And thanks to Professor Abul Kalam sir for nice presentation, an elaborate presentation, an excellent presentation, I should say. And thanks to the chairman, sir, Nazmul sir, and Prince, and my co-panelist, Professor Faiz, and thanks to the audience. Actually, as this topic is concerned with acute medicine, and GI bleeding is related to the acute management of the medicine, acute management. So we can say that management and diagnosis of GI bleeding should go hand in hand. Whenever we have to come across the patient of GI bleeding, either upper GI bleeding or lower GI bleeding, we have to go for management and diagnosis and side by side, in the hands on hands. This is the first comment from me. Another thing is that 2/3 of the GI tract bleeding to the upper GI tract and 1/3 from the lower GI tract. Another thing is that upper GI bleeding is can be managed more medically than the lower GI tract bleeding. Although there are some lower GI bleeding can be managed medically, but if we consider lower GI tract bleeding, mostly surgical actually. But 2/3 of the if you see the cause of GI bleeding, up 2/3 is related to the upper GI bleeding and can have to be managed medically. Another is the follow-up of the patient. A patient of GI bleeding has come to you in emergency. You are going to you are proceeding for diagnosis and management side by side, but at the same time we have to keep watch on the patient's physical sign like pulse, whether it is go for more than 100 or 120, blood pressure, whether the patient is going to shock. These important things. Another is respiratory rate, whether the respiratory is going high. Then GCS, whether the patient GCS is going low. And another thing is that urinary output, whether the output is going down less than 30 ml per hour or not. These vital signs, these physical findings should have to be assessed by the attending doctors whenever they are managing the patient of acute GI bleeding. With this few words and giving thanks to all of the participants, and especially our chairman sir, Professor Nazmul, and speaker Professor Abul Kalam sir, and moderator Shinjini and Prince, I say goodbye and good night and stay safe. Thank you very much. I have to go for another podcast. Thank you, sir.
Thank you, sir, for your nice and brief comment on this presentation. Our another panelist, Dr. Faizul Chowdhury, is not available due to some unavoidable circumstances. Now, I'd like to jump on the question answer session. The presentation was so elaborative that there is hardly any scope for question. But there is some question, that is Dr. Mizanur Rahman asked whether that upper GI endoscopy can be done in an acute upper GI bleeding in a patient who have postural hypotension.
Yes, that can be done. No problem.
Okay.
You have to find out.
Okay.
And definitely you have to find out whether it is peritoneal bleeding or at a non-varicose bleeding. So emergency upper GI endoscopy is done to identify the varices and also to do some endoscopic procedure to stop the bleeding. Thank you for the question.
Thank you, sir. There was some technical error. So when the investigation was explained by you, there is some technical error. Can you please explain the reason for doing gastrin level? Another viewer asked
Oh,
it.
okay. Gastrin level is not regularly routinely done. So, it can be done in some of the conditions, especially in the hypersecretory condition, especially in Jollinger-Ellison syndrome, when there is a an apprehension of gastrinoma. So, if you find that the patient is having recurrent ulcer, multiple ulcer, and also you can see that convoluted, increased mucosal folds in the stomach, then you can think of your gastrinoma, that producing your increased secretion of gastrin and thereby producing more hydrochloric acid to produce recurrent ulceration and multiple ulceration. So pancreas may be an important source of that gastrinoma. So you have to evaluate through that. And if the patient has got recurrent ulceration, no NSA and no Helicobacter pylori after eradication, so then you can consider in those patients about your hypersecretory gastrinomas. Thank you.
Thank you, sir. Another viewer asked, can you put some light on overtransfusion in case of varicose bleeding? The term of overtransfusion.
Well, the patient having varicose bleeding, that transfusion can be done if you find that the patient has got hemodynamic instability and the patient has got low hematocrit. So definitely we can go for blood transfusion, and the patient is having recurrent hematemesis melena. So no problem with that. We can go for blood transfusion. But the question of the is that whether if the patient has got renal dysfunction or if the patient has got along with cardiac dysfunction. So we have to go for looking at very important signs whether the patient has got over hyperhydration. So many importantly, that is very important that you have to go for blood transfusion. But remember that over transfusion should not be there. Thank you.
Thank you, sir. As we are running short of time, I would like to end the question answer session in this aspect. Now, I would like to ask Dr. Honorable Professor, Dr. and the Chairperson, Dr. Nazmul Ahasan, sir, to give his valuable speech and end the session. Thank you, sir. Nazmul Ahasan, sir.
Thank you, Dr. Shinjini Sarkar, for asking me to give some comment on this topic. Dr. Prince, am I audible?
Yes, sir. Yes, sir. Yes, sir.
At first, I want to express thanks to Professor Khan Abul Kalam Azad for his elaborate and wonderful presentation on this very important and common topic. You know, Professor Khan Abul Kalam Azad, he is one of the senior most legends of medicine in our country. And he graduated from Dhaka Medical College, but he worked long time outside Dhaka Medical College, particularly in Rajshahi and Bogra, so far as I know, because we worked together for many years in periphery also. So this acute GIT bleeding, the causes, management aspects, it varies from different hospitals in peripheries, in centers. So he has gained a vast experience, worked in periphery as well as now working in central. You know, this acute GIT bleeding, the cause varies in different countries. We always tell our students the common causes are peptic ulcer disease, drug erosion, esophageal varix. Still, I remember Professor Khan Abul Kalam Azad, possibly he will agree with me. We are student of Professor H.G.M. Chowdhury. Still, I remember when he used to teach regarding upper GIT bleeding, he used to say that whenever you get a patient, main principle is to identify what is the cause of bleeding, and second is what is the severity of bleeding. So you are to take a brief history, you have to do a rapid examination. Suppose if he gives a history of upper pain in the upper abdomen for a long time, you can think of peptic ulcer disease. If he is taking NSAID, it may be a case of drug erosion. But if it may be a case of jaundice, having a history of jaundice, ascites, it may be a case of esophageal varix. So history is very important. Then you have to do a rapid examination. You do not, if you do not get any pulse, you cannot record blood pressure, patient is in shock. So you have to rapidly, you have to start IV fluid, you have to give blood transfusion. History is very important. If you see that if after any bleeding, patient is in coma, then you can suspect it may be a case of hepatic coma. So this bleeding is, in case of hepatic coma, upper GIT bleeding always predisposed to hepatic coma. So this is, history is very important. At the same time, examination is very important. If you get jaundice, if you get a splenomegaly, if you get a splenomegaly, it will give hints to that this is possibly esophageal. So Professor Abul Kalam gave emphasis to all these important parts in history and examination, and also he gave elaborate informations regarding management of peptic ulcer disease. I will emphasize two other points. One is that management of GIT bleeding always a combined effort of physicians and surgeons. So whenever there is upper GIT bleeding, always involve a surgeon, because any time if you cannot control this upper GI bleeding by a number of blood transfusions or management, if there is failure of management, continues to bleed, then sometimes elective, sometimes emergency surgery may be required. So you always involved. Secondly, in our country, particularly, we think that always many patients are taking PPI and anti-ulcer drugs for a long time. So a lot of controversies whether during acute GIT bleeding we'll give eradication therapy, how long we will give PPI therapy. So it is said that if there is a history of upper GIT bleeding, you can continue this for a long time. Few other indications of continuing PPI in other conditions, but in our country, patients are getting hundreds and thousands of patients are getting PPI without any results. So from SCP chapter Bangladesh, we have been selecting some topics like acute emergencies. So this upper GIT bleeding and lower GIT bleeding, this is a very common topic, and we have requested Professor Abul Kalam Azad to give a talk on this. Thank you, Professor Abul Kalam Azad, for giving this time, for taking the trouble and giving this wonderful presentation. I am also thankful to Professor Faizul Islam and Professor Sujat, two more senior most professors of medicine, for contributing this seminar. I think all the listeners, audience, they are benefited like me from presentation of Professor Abul Kalam Azad. We have another presentation on next Thursday at same time. Professor Suhail Mahmood Arafat, Professor and Chairman BSMO, he will be giving a talk on acute pancreatitis, another important acute emergencies. I invite all the listeners for to join next program. Once again, I want to express thanks to moderator Dr. Prince, Professor Rubina Yasmin. He's organizing this topic and this presentation. Finally, to to the listeners and audience. Thank you again. And at the end, again, once again, Professor Khan Abul Kalam Azad, for your wonderful presentation. I conclude here. Thank you. Thank you.
Sadly, we have come to the end of today's program. We have learned so many important things from Sir today. Many thanks to the speaker, the chair, the panelist, and last but not the least, the moderator Apu for managing time for this program from their very busy schedule. I would like to thank all the audience who were with us, especially those who asked many important questions. Our next health talk on acute medicine will held on 19th of August, where Professor Sohail Mohammad Arafat sir will discuss on the topic acute pancreatitis. So, see you all in the next episode. Until then, take care.